Welcome once more to this ERAS Cardiac Society webinar presented in collaboration with CTSNet, Chest Tube Management and Cardiac Surgery. Thank you for joining us. Please note this webinar is being recorded and will be available next week on ctsnet.org and CTSNet's YouTube channel. At this time, I'm pleased to introduce the co-moderators for this webinar, Dr. Kevin Lobdell and Dr. Mark Gerdish.
John, thanks for that, and thanks to our audience for making the time today to explore this look into the science of drains, or what we popularly call drainology. I'm excited to introduce our renowned international colleagues, and we'll start with Mark Gillinov, who's chairman of the Department of Thoracic and Cardiovascular Surgery in the Sidell and Arnold Miller Family Heart Vascular Thoracic Institute at the Cleveland Clinic. He holds the Judith Dion Pyle Chair in Heart Valve Research and is also the chair of the Cardiothoracic Surgical Trials Network. He's director of the Center for Atrial Fibrillation at the clinic, and unfortunately he's not able to join us today live, but has a pre-recorded presentation which you'll find fascinating. Subsequently, we'll transition to Professor Kalisnik, who joins us from Paracelsus Medical University in Nuremberg, Germany, with special interest in minimally invasive cardiac surgery, the surgical treatment of arrhythmias, and research which includes AI in its relation to complications such as dysrhythmia, AKI, deep sternal wound infection. He's also developing a network and working through Medical University in Ljubljana, Slovenia, as well as out of Graz, Austria, and a network there. And then our third talk, which will be followed by discussion, is via Professor Conradi, who's been a leader in minimally invasive cardiac surgery and transcatheter valve procedures for many years as a senior consultant at University Heart and Vascular Center in Hamburg, Germany. He'll soon transition to the chief of surgery at the Heart Center in Cologne, Germany. He's published over 300 scientific articles and has served on several national and international guideline committees. Joining me for color commentary is the famous Mark Gerdish from Indianapolis, so we'll look forward to his input. A quick reminder to our entire audience during the presentation that questions may be entered for our panelists via the Zoom QA function. Again, there's 3 presentations. Following the third presentation, our panel will open to general discussion and the input via the Q&A. So again, thank you for joining us. We'll start with Dr. Gillinov's presentation entitled Clinical Implications of Retained Blood Syndrome.
Every cardiac surgeon wants the operation to be perfect. And part of having a perfect operation is to have excellent postoperative care. Our patients all get chest tubes, and it is extremely important that the chest drains remain open to prevent retained blood in the mediastinum and in the pulmonary spaces, because retained blood causes problems. When we put a chest tube in, we assume it is going to stay patent and it's going to drain the patient and let us know if the patient has excessive bleeding. The goal is complete evacuation of all blood and fluids from around the heart and lungs. And as I mentioned, failure to drain adequately, retained blood causes problems. It causes the need for reinterventions, longer length of stay, complications, and a higher cost of care. Now, nurses try to keep the chest tubes open. They beat them, they open them, and all of this is a poor use of ICU nurse time. The nurse has to manage the blood pressure, the hemodynamics, and should not be bothered by having to worry about chest tubes like these pictured that are filled with blood. Oftentimes, we look at a chest tube in a patient and we say, it's fine, it's doing well. Well, you can't see the inside of the chest tube. And we had a study here at the Cleveland Clinic in which patients had opportunistic CT scans after cardiac surgery with chest tubes in place. And we decided to ask the question, these chest tubes that are in place, how many of them are clogged? And the answer was 36% of cardiac surgery patients had completely occluded chest tubes at the time of these CT scans, and 86% of the time, the occlusion was inside the patient, meaning you couldn't tell, you couldn't see. That means that we need a means of keeping chest tubes open, keeping them patent and draining blood. Because if we do not drain the blood, we get complications. 20% of all cardiac surgery patients have problems related to retained blood and need reinterventions. They can be pleural effusion, pericardial effusion, hemothorax, and worst of all, tamponade. These interventions to treat the problems caused by retained blood are expensive, patients don't like them, they increase length of stay, and they are associated with complications, whether it be thoracentesis, pericardiocentesis, insertion of a new intercostal drain, or in certain cases, even re-expiration. All of these are avoidable if our drainage systems stay open. We know the steps of retained blood syndrome that lead to the problems. Acutely retained blood can cause tamponade and a hemothorax, but we also have subacute problems like pericardial effusion and pleural effusion, which can lead, if undrained, to constrictive pericarditis and fibrothorax. Well, what are the consequences of these clinical entities? Here in gray, we see patients with retained blood, and in orange, no retained blood. And there is a higher incidence of every postoperative complication if there's retained blood in gray. More post-op AFib, increased time on the ventilator, more infections, more time in the ICU, increased mortality, and increased readmissions. How often do these retained blood syndromes happen? In different reports, it varies from 16 to 23%, but just in general, if you look at this curve, about 18 or 19% of all patients will have retained blood syndrome, meaning they have retained blood that wasn't drained, that caused a problem. And when we think about this, we realize that postoperative morbidity, even morbidity that's minor, it wasn't a stroke, it wasn't an MI, it wasn't a death, but this sort of minor morbidity leads to increased length of stay, increased costs, and can really ruin a perfectly good operation. Now, other studies have demonstrated the link between retained blood syndrome and postoperative atrial fibrillation. In this study published in Lancet, a posterior pericardiotomy, which allowed the blood to drain from the pericardium, was associated with better outcomes than standard chest drainage. And here we explain the physiology and biochemistry. How does retained blood cause inflammation and problems? So the science really fits very well. And here's the mechanism. Retained blood, chest tube clogs, you get inflammation and tissue damage, which activates a whole bunch of inflammatory mediators and free radicals, which lead to cell damage and atrial fibrillation. Keeping chest tubes patent has become part of our ERAS guidelines for enhanced recovery after surgery, particularly after cardiac surgery. So the way we think of it is this. We wear a seatbelt all the time because you want to be safe all the time. We don't wait for there to be a big problem. We try to avoid the problem. So avoiding retained blood syndrome, keeping the blood where it's supposed to be in the chest tube canister is an excellent way to reduce complications, reduce reinterventions, and reduce cost. Thank you.
That was great. So please continue to consider using that Zoom QA function to post questions. And now we'll transition to Dr. Kalisnik and his presentation. Do different management strategies for chest tubes impact the outcomes in cardiac surgery? Welcome.
Thank you, Professor Lobler. It's a pleasure for me to be here. I'm just sending the greetings from Austrian annual meeting of the Society of Cardiac and Cardiological community. And as you see, maybe you cannot see, but it's raining, so we are going to focus on the science instead of enjoying Salzburg. Let's share the screen. So after the beautiful presentation of Dr. Gillinov from Cleveland Clinic, I would like to focus on a little bit of a practical point of how we try to follow that paradigm of reducing the morbidity and mortality after surgery in the scope of enhanced recovery after surgery in practical clinical day. So the question would be, does it really matter if we use a different system, a different chest tube? And I would like to start with a little bit of a concept we are following at the Paracelsus Medical University. So, of course, like everybody, we want to have a patient completely prepared for the operation, prepared, properly indicated. Then, of course, we perform the best surgery, what we think we do. But then, of course, the day hasn't ended. Then we have to do everything that we detect, recognize, and also treat the complications, and of course, support the patient to recover safely and quickly. Having said that, we are witnessing the progress of from full sternotomy to almost chest whole surgery. Of course, we have also on the podium on the professors in moderating place that are actually the pioneers of that. And one would consider it, okay, maybe we don't need drainage if we have such a small holes and such small trauma and injury. Well, actually, if we take a look at the benchmarking of one of the best databases in the world, we see that we still have, even at the most simple surgeries, 30% of morbidity. And many of those complications can be attributed also to bad drainage after surgery. So actually, we have a place for improvement. And this is actually very nicely explained in the publication from the Enhanced Recovery After Surgery Board. So, with a question, do the chest use management really affect surgical outcomes? After we see that tables, that metrics, I would like to reparaphrase. Knowing that the drainage to chest tube clot and stop, we can ask ourselves how actually our, so to say, how our procedures or how our chest tube management really affect the patients. Having had said that, and taking into account it carries many complications, we will have a look today at the active clearance and digital drain systems of chest tube management at Paracelsus Medical University and the related outcomes like re-exploration, pericardial effusion, pleural effusion, tamponade, and of course the other two, post-operative atrial fibrillation, the most important mortality and hospital length of stay. I would like to introduce just practically three systems. Conventional on the left side, and in the middle is a active chest tube clearance system with any container associated. That was very nicely described and also mentioned by Professor Gillinov, and there are many studies in that field involving active chest tube clearance from Montreal Institute of Canada. And of course, on the right side, we have the Medila portable digital system, which has been introduced in the last time we have started using it in 2018. Sorry. Before diving into our patient group, I would just present the nice presentations of the nice results from the Montreal group. So they had the reduced exploration of bleeding and tamponade and increased chest tube patency by using that new technology. And they have, in that publication, they present the borderline, and the other publication, they have significantly reduced the incidence of postoperative atrial fibrillation. So in a similarly big group, we did the same study already 80 or even more years ago, and came, this is just illustration that we did of a matching on the left, we came to that actually to that conclusions. We could demonstrate the reduction of atrial fibrillation by 33%, and we could see the reduction of retained blood syndrome by almost a half. So I would just move a little bit back, because I want to say and demonstrate how we proceed with our chest tubes. So one back. When we have active clearance drainage system constellation, we had placed them in the retrosternal position always, and of course at the wall suction we applied a pressure of minus 20 centimeters water. And if we needed more chest tubes, then we used the epsilon connector, or may associated that in a single way with the drainage canisters. In that case, we used the pleural teleflow Morrisville. How was the protocol for drain, so to say, removal and placement? We fitted all patients, being with medulla or with clear flow, with 28 French chest tube in anterior mediastinum, and then when opening any of the pleura, we put additional drainage. And this is a kind of a very important point. We try to insert also pericardial tube when we perceive at surgeon's discretion, when the surgeon decides it's going to bleed, or it is necessary because we want to avoid the tamponade with a patient that has a high risk of bleeding. And typically all the chest tubes are then removed routinely on the second postoperative day if the amount of drained fluid does not exceed 150 milliliters. So having said that, and having shown that results of the active clearance, we go now to the next one. The next clinical group was the medulla application. That is a very, so to say, appealing digital and quiet device that has a suction mechanism on board, and it's portable. So we just wanted to, because we wanted to transfer early from the intensive care, we introduced that at the clinic in 2018 with the similar or almost identical device constellation as ATC technology. What did we do retrospectively? We wanted to see if that device, in conjunction with all the chest tubes applied, performs similarly to our ATC device before. But this time, of course, in this analysis, which I'm going to present, we wanted to a little bit homogenize the group. So we paid special attention to have the sinus rhythm patients and elective myocardial rescue patients with all the exclusion criteria listed above. So this was the patient flow diagram of the portable digital study. At the end, we ended after all the selective, so to say, selective exclusion of potential confounding factors. We ended with a final group of portable digital of almost 500 versus a little bit less than 400 patients. Here, this is not actually intended to discuss all the results. It's a very busy slide. we just wanted to say everything that was not insignificant, we tried to propensity adjust. And here I would like to point that drainage volumes, they were pretty much the same, except for the frequency of the drained blood in the containers of portable digital drains. Here we could harvest, or we could see always a little bit more blood than the patients without that. Now I would like really to go to the main results of that last series. We see that also, and especially in this group with the portable digital, we could demonstrate the reduced rates of retained blood syndrome. Early exploration, what does that mean? Early exploration we defined in a strict sense to represent all the explorations in the time while chest tubes being in place. So we see at the adjustment, they are borderline significant and highly significant even for after adjustment, reduced rates of postoperative atrial fibrillation. Now I would like to go a little bit one step forward. When we take the definition that is commonly accepted in the community, so including all the tamponates and the explorations for bleeding, adjusting for all the postoperative variables and perioperative variables, then please have a look. Then we can see that retained blood syndrome highly adjusted and correctly reduced in that group. Re-exploration for bleeding is at this point also significantly reduced in portable digital drain group. The postoperative atrial fibrillation reduction remains after adjustment the same. So, of course, that was a kind of that was a non-inferiority. We just wanted to show that that our systems improve or maintain the same quality. But see, here we saw the superior results, so we wanted to understand. As you see now in the left upper corner, the portable digital drainage system seems to drain more blood at the very beginning, at the immediate, so to say, at the immediate closure, already in the operating room. What does that mean? That could mean that maybe it prevents the blood from clotting outside the heart in the pericardium. And here I would like to show how the conventional drainage performs in relation to better technology or improved technology according to the mechanisms. So acute active chest clearance and portable digital drain. As we see, we could answer chest tube management does impact related outcomes, and it impacts those outcomes quite significantly. That is still not reflected in the mortality, maybe probably also due to insufficient number. Let me conclude with a final take-home message. We believe that for a good functioning chest tube management, we have to have immediate effective suction. We have to have the chest tubes at all times open. Then, of course, very important, and just briefly mentioned, the posterior pericardium should be clean at all times. And now I would like to add maybe some look into the future. We should improve monitoring to detect threatening tamponade, even by means of artificial intelligence mechanisms. Thank you for your attention.
Thank you, Professor Kalisnik, for adding that. It's great to see these leaders developing the science behind these areas, making connections to things that I think historically we really didn't think about. And that's a great segue to Dr. Conradi or Professor Conradi's presentation. Posterior pericardiotomy should be the standard in cardiac surgical procedures. Let me remind the audience to continue to enter questions via the Zoom Q&A. Everybody have a look at those, see if it catalyzes more questions, and Mark Gertish and I will get to those at the end. So next, Dr. Conradi, thank you.
Thanks, everyone. So first of all, let me thank the ERAS Cardiac Society and CTSNet for inviting me to this webinar. So as the last speaker of this webinar, I was asked to talk about posterior pericardiotomy, and I entitled it that I think it should be the new standard for open cardiac surgical procedure. I hope I can persuade you of that in the next 10 minutes or so. So these are my disclosures. So I agree completely to what's been said before, right? A perfect operation can absolutely be ruined by something as seemingly, not important as drainage and watching the drains. But what if there was nothing to drain? What if we could prevent fluid collection to occur altogether? This is not a new idea. The technique of posterior pericardiotomy is really old. This is the first publication on the topic, which is almost 30 years ago, where that simple slit in the dependent portion of the pericardium, as you can see in the cartoon, resulted admittedly in a limited number of patients, as you can see in the tables to the right. However, this was a randomized study. It did result in reduction of important endpoints such as arrhythmias, atrial fibrillation, and so forth. So seemingly, this simple maneuver works to reduce these endpoints. So what are we talking about, actually? This is a little video that I found on the internet, which demonstrates the technique. This is a cannulated heart, either before or after your cardiac procedure. You can do that. This is the dependent portion. The forceps are pointing to the left side of the phrenic nerve right here. And the dependent portion is the location that you should aim for your posterior pericardiotomy. And all you do, actually, you slit the pericardium open over, a few centimeters, 4 to 6 centimeters. This is a maneuver that any one of us can easily do, at least in open cardiac procedures via full stenotomy. It costs virtually €0 or dollars or whatnot, and it is also virtually risk-free. So I don't really see why it should not be done. You may not believe in it, but still, you're not really harming anyone with doing it. And on top of it, I hope that I can persuade you that it does help. This study, I think, has been mentioned before very briefly. This is quite recent, 2021. And, if you can give me another prospective randomized surgical trial published in the Lancet, I think there's not too many of those, right? So I'm not saying big names, are always truthful, but it is a hint, right? This is a prospective, as I said, randomized controlled trial in the Lancet published. Patients were randomized 1-to-1 to receive this simple maneuver, posterior pericardiotomy, or not. And this was done in patients receiving coronary surgery, aortic valve surgery, ascending aortic surgery, AV valves, so mitral tricuspid were excluded because, of course, there's an inherent risk from atrial fibrillation, which is one of the primary endpoints here with the disease entity. And these are the primary outcomes. Post-operative atrial fibrillation, 18% in the intervention group, 32% in the non-intervention. So almost slashed in half just by that 2-3 minute procedure, which comes at no cost. And of course, this went along with reduced pericardial effusion, also a relative risk of 0.8%. So for me, quite, persuasive results here in an overall patient population of about 400 cases. That same author, Mario Gaudino, who's been well known for well-designed meta-analyses, published on the topic a year later, summarizing what there is in terms of evidence. And what he found was 18 prospective randomized controlled trials, about 3,500 patients from different geographic locations, including different kinds of surgeries, as you can read up on the lower half of that slide. And I can go through these quickly because virtually in all endpoints, highly clinically significant effects were seen. Early pericardial effusion, late pericardial effusion, look at the p-values here. Cardiac tamponade, highly significantly reduction and postoperative atrial fibrillation, which, by the way, is an entity that I think is too often considered benign, but which certainly is not. It does come at a little price. Pleural effusions were increased by 0.02% p-value, so significant. However, these were not pulmonary complications. These were, more or less the same. And pulmonary complications are, defined as something like an additional drain needed or pneumonia and things like that. So there is a signal, but it's not something, that's overly severe. And then if that wasn't enough to persuade you, there was another meta-analysis in a cardiology journal now, 25 prospective randomized controlled trials published last year, Euro intervention, 4,500 patients. And to make a long story short, overall incidence or frequency of postoperative atrial fibrillation reduced from 23.7 to 11.7%, and they refined their analysis to remove studies with, use of postoperative beta blockers, periodic beta blockers, or stratified by type of surgery. Still, effects remained. And in terms of atrial fibrillation, this is the graph that they show. Again, roughly half or slashed in half by that maneuver. Length of stay also reduced. This is something that's quite important nowadays, right? In the ERAS era, if you want to call it that, if you have a nice ERAS program set up, why ruin it? But because people or patients need to stay because of repeat echoes or pericardial sonographies, things like that. I don't think there's a reason not to do that. Now you can say this is this guy's crazy idea, but it's certainly not, because it is now firmly embedded in international guidelines. These are the 2023 North American guidelines on atrial fibrillation. And just watch the flowchart here to the lower half of that slide. Posterior left pericardiotomy is recommended in a 2A recommendation to prevent postoperative atrial fibrillation. And this is given a level of evidence BR, which means evidence from one or more randomized controlled trials or meta-analyses, which is exactly what I just showed you. So I'd like to conclude to leave us some time for discussion. Posterior left pericardiotomy certainly is a technically easy and quick maneuver. It is virtually free of complication. And I hope I could show you that it is associated with significant reduction in many endpoints, including post-operative atrial fibrillation, something that has drawn a lot of attention recently. I think, and this is not so much topic of mine, but more of the previous presentations, that the pericardiotomy effect likely is mediated by reduction of pericardial effusion and local inflammation. For me, it should absolutely be standard in open full stenotomy cases, and this is also set in the guidelines. And by the way, I think the CTSNet community is trialing this again associated with the EPIC trial to confirm or reconfirm the findings that I presented you with. And with that, I'd like to thank you for your attention, and I'm looking forward to a lively discussion here.
Thanks, Professor Conradi, for both presenting that and reinforcing this important concept. We'll reinforce the opportunity to put questions in that Q&A function, and Dr. Gerdish is monitoring that. What I will forward just before we transition is this reflection that I've had as we listen to this and think about it. And it's amazing to me how we can become habituated to common things like chest drains and take them for granted, while simultaneously we're developing these exciting opportunities to develop insight, transform science through intelligent computing or things like AI, machine learning, or whatever category of that, to be able to develop associations that we couldn't have begun to understand, let alone commonly overlook. So with that, Mark, you've been monitoring that closely. Do you have some questions that you want to throw in there and catalyze some good discussion?
I do. Those were great presentations. And I think our feet are to the fire on the posterior pericardiotomy at this point, guideline-directed therapy for people who have an open sternotomy, which I think we're going to have to bust a move on that. It's super interesting. The thing I would ask, though, do you have to put a drain in the left pleural space then?
Well, you know what? I'm quite liberal in doing that as it is. I personally, I do that, yes. My technique would be to do the pericardiotomy first, because I tend to forget, I have to admit, right? Small maneuver. And put a drain in the basal portion of the pericardium to start out with, then do my procedure, and afterwards replace it as I would from the xiphoid space towards the left pleural drain. I know that Mario, I think, leaves the drain in the posterior pericardium and lets it, look through that incision a little bit. You can do that, of course. I like a pleural drainage on the left side, and I don't think it hurts much.
So patients need 2 drains then.
Yes, that's it. I need an anterior one, post behind the sternum, and one to the left, pleural.
Yeah, I mean, I think that'll be a little bit of a point of resistance for those of us who don't put 2 drains in, but it's really great presentation, obviously. One of the things that came up, and I would ask both of you to chime in actually, because it dovetails into what we just talked about. How many drains? How big do the drains have to be? Where do they have to be? Should they go in through the chest wall on the side? Should they be subxiphoid? Are there implications to those things? Does it matter how big a chest tube is? So we could talk about that for an hour, but there's kind of a recurrent theme in the questions that goes to this. So if each of you could just chime in on kind of the 1, 2, 3, how many drains, what size, where they have to go.
Yuri, do you want to go first?
Yes, of course. I would take 28 silicon retrosternal, 24 pericardial, and of course I would like to put a suction of at minimum -20 on a normal bleeding patient. And if we have maybe extensive bleeding, I would increase the suction. And I can go.
Very good. I use 28s, all locations. As I said, I'm liberal in draining the pleural spaces. I do posterior pericardiotomy in all sternotomy cases. I don't know if anyone has ever attempted doing it from a mini thoracotomy. I don't know if it's possible. I don't think so. I don't really think so. I don't like intercostal space, to transverse intercostal space as much. There is a certain risk if you reach a certain case number to injure something, either by implementing or by pulling them out. I think it's not really nice for patient comfort because it's painful. Intercostal spaces are painful. So everything comes from the subxiphoid region for open cases. You can discuss, do you need a left pleural? Can you do it in a dependent portion of the pericardium? Do you do both? I think the minimum for me, left pleural, if I do the pericardiotomy in retrosternal.
Yeah. So I think that, for us, since we went to active chest tube clearance, we've gone to essentially everybody just uses a 24 French tube because we found that it didn't make any difference what size the tube was once we had active clearance. And then I went to just one tube. Just 124 French chest tube is what I use for 99% of my cases. But it's in the setting of having active clearance so that the tube is always open, and we have the benefit then of knowing whether there's bleeding and then being able to get it out and not having it occlude inside, as Mark Gillinov pointed out earlier. Dr. Kalisnik, there are a couple of questions about suction and how high, how long should you keep suction on for the duration of the chest tubes in? Do chest tubes, and in your data, did the chest tubes come out sooner or later with continuous suction? So can you give me the suction protocol and the timing of chest tube removal?
Yeah, actually, we have at least 2. Because a normal protocol in Nuremberg was under Professor Fischlein always -20 and continuously without any consideration taking it the next day out. And it was a prolonged drainage, so to say, volume. Then we extended it for another day till it was very, so to say, serous and not bloody, the exudate. And of course, we are trying to implement because I have a privilege now to work also since a couple of months ago on the other side, academic center. We have implemented the portable digital, and we also implemented mitral minimal invasive surgeries, the Blake, and the other one, the Redex. And additionally, if they bleed, we increase it to -30, -35, till we have the interactive column. We are going to put that in. We're going to publish it so that many others can take advantage of it or maybe discuss with us. And of course, very important. Before the removal of the next day, we stop the suction. We stop the suction to see if everything's stable. This is maybe a minor modification.
So just to be clear, though, when you compare the two groups, the protocols were early pull on regular chest tubes at 20 centimeters, like you always had, versus longer duration continuous suction with a monitored device. Would that be accurate? Or because those are the two protocols you just described.
What I'm focusing on is now both protocols, now the new ones. Of course, I'm discussing the new ones. The first one was just normal protocol, -20, and stable, pulling that out. The other one, because we don't want to have that drainage of a serous fluid, what we because of the irritation of the pericardium, we now cease that pull 6 or 4 hours before. So it's completely, so to say, quiet, the drainage.
Okay.
That's the minor modification. Because we of course, after 12 hours, the drainage is almost zero if you have such a normal patient with no surgical bleeding issues.
Right. So I'm not going to belabor that too much longer, but these are the fine points of chest tube drainage. And, once we started active chest tube clearance, we got our chest tubes out sooner and also shortened our length of stay because of that. So I think that those nuances of implications of the aesthetic of a big or small tube, how many tubes are there? How uncomfortable is the patient? How long is the suction on? How long do you have to carry the thing around? Those are all things that we're going to have to all put together and try to paint a picture for people to what makes sense. Because all of those things are alluded to in the questions that we've had so far. Kevin, did you want to chime in on any of that?
Yeah, that was great. So thanks, Mark, for that rich perspective, because you've been at this and thinking about it deeply for a long time. One of the things that comes to my mind as we contemplate this is sort of non-inferiority, right? Almost like transfusions. And it seems to me that what we're converging on in cardiac surgery is less is almost always equivalent, if not more. So I gave a provocative talk at the European meeting about one tube, one cut, meaning the posterior pericardiotomy, and 1 day is maybe an optimal way. Obviously, some rare exceptions. I'd be the first to say that's flavored somewhat based on experience. I've worked in the congenital world where we used one tube and we had it in 1 day and we took it out and we thought we were doing a great job. And I think it was in a leading center. So, I feel like that was valid. Similar experience in the adult world at the very beginning of my training. So with that in mind, what do we think about moving towards that KISS principle? Keep it simple, stupid, right? Something very simple that everybody can do, and then apply these techniques like AI to try to learn about these associations that historically we may never have thought were related, but as we're talking about it now, are truly related. Thoughts?
Yeah. Dr. Kalisnik, any thoughts on that?
Actually, what I would like to maybe go a little bit to have a look at the future. Thank you. This is very visionary. What I would like to say, that holds true for the 90 to 94% of patients. What about those 6%? They cannot afford having had one chest tube for maybe one incision for 1 day and pulled out. So I would provocatively challenge the community. Let's define those 6% of patients, because there we have to have a different strategy, but let's go with that proposed strategies for the other 94% of patients.
Yeah, so finding them, right? You don't know who they are until you have the problem, right?
Yeah.
And Dr. Conradi, any perspective on that as far as duration of drainage? And I would also throw in, does anyone, I mean, do we know if, tubes are supposed to come out when the drainage is less bloody, when it's just serous, and is there a volume threshold? We have our protocols. You have your protocols. Dr. Conradi, do you have any insight into those things?
Yeah, what I was thinking, the easy answer always is, you'll have to do it on an individualized basis. Everyone's calling on us to think about individualized medicine. If you do so, though, patients say, oh, well, that's the easy answer out. Well, what about general recommendations? Still, I think it's valid, right? These things depend on the type of patient. Is there any coagulation any pathology? What about the access? Is it a large access with a lot of surface? Is it a minimally invasive, maybe endoscopic surface where there is simply not so much that can bleed? There, I would absolutely agree. What I think is important, especially with ERAS patients, it's not only simple things like drainage volume. That tells us nothing, basically. It can mean anything and nothing at the same time. I think it's important to do a quick transthoracic sonography of the thoracic chambers, check for retainment of fluid. That should be at least as important as drainage volume. If there's any doubt, try to clear your drains. Try to take out as much, mobilize the patient, maybe with the drains, as what we do in the ERAS before we pull them out. These are some of my thoughts around this.
So I think those are, sorry, Kevin, but I think that does summarize some super important points, right? When you say there's a lot of drainage, there's a little drainage, we just don't know if there's fluid there that just hasn't come out, right? Mm-hmm. And this is one of the things the kind of spectacular things that has happened in our practice with respect to the change in our management, because with active clearance, we've learned that if there's nothing coming out of the tube, there's nothing in there. And so we don't do echocardiography. And in fact, now, because we're so certain of the amount of bleeding on the short end, we're at about 75% all comers extubation in the operating room because we're not bleeding. We know we're not bleeding. So I think that really understanding the implications of tube patency is what we're getting at, and whether those tubes are in the right place and whether they actually evacuate the fluid that jeopardizes the patient. Someone had said something earlier, and I think it was you, Kevin, about kind of the incidence of things, and what we're really after is those things that are infrequent becoming rare. And that changes, the entire experience for the patients. I think that much of what we're talking about, as you've all pointed out, are the things that really rock the boat for the patient in the hospital. Yeah, they still get out of the hospital, their valve is fine, everything else looks good, but the experience may or may not have been a pleasant one. Kevin, you were going to say something?
Yeah, in the context of, let's call it complexity and the teams that are associated with it, it's always useful to think in terms of, say, low, medium, high risk. I'm being somewhat simplistic. So what are we going to do in the low risk? What are we going to do in the median? What are we going to do in the high? And then have that laid out. Another framework that I've often found useful is the Gillinov framework that speaks of simple or clear is the newer term they're using, complicated, complex, and chaotic. And what you really want to outline is, what are you going to do in each of those categories of risk? Who's going to do it? How are they going to do it? In other words, you have to have a way of thinking about these things, even if you don't have all the answers. And I think that's incredibly important.
Yeah. So thinking of that, and we've heard, protocolization with respect to management with continuous suction devices, et cetera. One of the things that comes up and came up in the questions, and that I've addressed many times with programs around the country, is what it's like for the nurses. And for us, standardization, protocolization, algorithm that's always the same for every human being has led to our success. I'd like to hear a little bit from our guest lecturers on kind of how their protocolization, algorithmic approach, and nursing feedback has been.
So maybe, if I may, I think one thing that's a little overlooked is, we all know where bleeding comes from, where the fluids come from. It is because you create, a source of bleeding. And if I think back on my training, at least for stenotomy, gaining and closing access was somehow belittled in a little bit, in a sense, right? You were left more or less alone in the OR after seeing it a couple of times and saying, well, call me if you have an issue. That's not the way to do this. We should train this in all earnesty. We should train people how to do a clean sternotomy, right? For as long as it takes, because this is so important. Same is true for closure. You know, there's so many, young physicians who are at unease closing the wound, not daring to ask the senior guys. That is stupid. I'm really sorry, but this is not good. This is, leaving someone at a loss. And in the end, it's a patient who pays. So I don't think there's any way to justify this. Train your residents in clean sternotomy, clean sternal closure, and at some point, of course, minimally invasive access. So this is all around the topic of prevention. Right? And then, of course, patients need to be educated on the things that we take for granted in this circle of speakers. We know that a drain that's not producing fluid may mean that there's retainment. But, it's not that common sense maybe, or not that well, known. So I congratulate the societies of doing webinars like this on seemingly non-attractive topics like drainology. This is very, very important.
Dr. Kalisnik?
Yeah, one quick point. Of course, also for the young colleagues, we have to be aware that the drains clot in the OR already. So let's be aware of that. Let's be aware of potential kinking, everything, so that we really have the patient with the functional drains out of the operating theater. That's one. And second, you addressed, Mark, very, very, very nicely, the assistance or the help of the nurses. It's very important that we explain, that we teach the nurses at the department that they pay attention to the right things, and at the same time that they are not, so to say, burdened with that, taking the notes, recordings, everything. So we really have a high level, not only satisfaction among patients, because let's say the new technologies, they enable the efficient drainage, they are quiet, they are not painful with the 28 French, but also the nurses, they are very satisfied seeing the displays, reading, maybe spared a lot of, like the Dr. Gillinov says, a lot of good time can be spared in an efficient way. If we have a good devices, with a good recording possibilities, and of course, educated personnel.
Right. So I actually think two super important points, right? So since we've had active clearance, we always know our tubes are not kinked and we know they're open leaving the operating room. And I think that's really important, especially in larger folks where the chest tube can take kind of an odd course. And then you might think you have an open chest tube and you don't. And then with the nursing, that's the other thing that we've really enjoyed. Right now, if we tried to take active chest tube clearance away, our nurses would walk off the job. So it's become ingrained in them because they see the impact and understand the technology. There's a question here. There's two questions I want to bring up that are on our list. And one of them, I think, goes to kind of philosophy and strategy and surgery standardization. And it says, we definitely need some standardization regarding chest tubes. Every one of our surgeons manages them differently. Great work, ERAS, Cardiothoracic says it. So I'm going to put that out there. I think everybody's just going to nod their heads in agreement. Everybody has to do it the same way in any program, or you cannot achieve excellence in drainology. Would you agree?
Yeah, Mark, let me take that because that's exactly what I had raised my hand. I didn't want to interrupt, but one of the things I've shared with our team for the last 20 years is success often comes from doing common things uncommonly well. But the corollary to that, Brent James from Intermountain said years ago to a team of surgeons, it's more important to do it the same way than the way you think is right. And related to that, the great thinker Carl Weck from University of Michigan, who talked about the collapse of sense making in organizations, gave this great anecdote, but the punchline is that a bad plan is better than no plan. And I think what you're saying is if everybody's doing it differently on different days of the week and different patients, to the nurses, that looks like no plan. And so if we say we all do it the same way, Monday through Sunday, regardless of the case, and there's a few exceptions, they can begin to recognize the patterns, like this works or this doesn't work. And when that happens, we do this. So I think that's the magic behind the uniform approach to these things.
Right. And that is a segue into another question. So Joe McHugh asks, thinking about cost containment, is there a cost difference between traditional drainage systems and digital drainage systems or active chest tube clearance? And this goes to the heart of much of what we've talked about, right? Which means when you bring evidence to a programmatic change, that evidence should, in its offing, in its beginning, have that kind of nugget of potential where you're going to change the course of things. And then evidence is collected to support it. And then if there's an investment, you prove the return on investment. Everything we bring into our program costs money. But we take on the task of proving the ROI, but data collection. How did you manage that, Dr. Kalisnik, in your digital system?
Well, actually, I was fortunate. I was attending surgery in the team from Professor Fischlein. He had to fight. So I'm really thankful. He's a visionary. And of course, that was really what you say, an investment was that. And with that investment, we learn a lot. We learn continuously. And we are going to actually also improve the outcomes also in the future. And now maybe now that next question applies to me. We are starting the second site here in Austria, and this is also not a big, not a small investment, but of course the director of the program and also the management, they know about it. They have been informed, and they are saying, okay, if this is the price for clinical excellence, not just minimally invasive program, let's take it. Interesting.
Yeah, and I know we only have like a couple minutes left. I think there's a specter that I think we have to get on the table, which is chest tube milking, right? So just as an aside, I think we have to cover that at least briefly. I used to be a milking addict because I couldn't just stand there at the bedside. I had to milk the chest tube. Would either of you, Dr. Conradi, any opinion on chest tube milking?
Well, I do it as well. If I stand there, we're waiting for, the echo guy or something else, you still do it. I agree. It's somehow intuitive. I don't know if it makes a lot of sense though.
Yeah, I mean, once we switched to active clearance, that disappeared for us, of course, because we know the patency of the tube. I don't suppose there's any milking going on with the digital drainage system, the variable.
No, you don't see that anymore. No.
Very good. Kevin.
Hey, Mark, that was great. Yeah, we're 2 minutes, so I think we'll wrap it up. Mark, thank you for joining Yuri, Leonard, Mark for his recorded talk, and thank you to CTSNet, as well as ERAS Cardiac Society for helping us create this webinar. For those that aren't aware or haven't looked recently, we would ask you to consider visiting the website erascardiac.org and explore the various educational opportunities that are there. So again, thank you to each of the participants here, our teams, the people that are out there listening, learning, trying to improve, as well as ERAS Cardiac Society and CTSNet. So thank you very much, and everybody have a great day.
Thanks. I'm going to add one thing. There are some questions that went unanswered, and I'd like people to know that they can reach out to any of the people to get their questions answered. And yeah, thanks everybody. Have a great day.
Thanks, Mark.
Have a great day. Bye.
Thank you for attending this ERAS Cardiac Society webinar held in collaboration with CTSNet. As a reminder, a recording of today's webinar will be available next week on ctsnet.org and CTSNet's YouTube channel. For more webinars and other breaking news in cardiothoracic surgery, be sure to go give us a visit. As mentioned, additional educational content is available on the ERAS Cardiac Society website. You may visit the website address provided or scan the QR code to learn more about the ERAS Cardiac membership. Have a wonderful rest of your day.